Hello people, in this video let us look at bisphosphonates. Actually it's not biphosphonates, okay, it's bisphosphonates. Not sure why they put an S here. It could have easily been a biphosphonate, but it's a bisphosphonate. Look at the structure here, bisphosphonate. You have two phosphorus here and some side chains. So this is the generic structure of bisphosphonate. And then here you have the structure of alendronate. Alendronate has this side chain, right? So this is about bisphosphonate. So that is why they are called as bisphosphonate, because of their structure. Now what exactly are these? We are looking at pharmacology, right? So now look at this. Bisphosphonates, they are they inhibit bone resorption. That means bone being damaged, bone being losing its calcium. So it inhibits. So it's going to protect the bone. So did you understand what bone resorption is? That means deterioration in the calcium level in the bone. That is bone resorption. So it's going to inhibit that. So the bone will become stronger. There will be no osteoporosis. So there's going to be prevention of osteoporosis. So this is bisphosphonates are the most effective anti-resorptive drugs. They also treat hypercalcemia. They reduce the calcium levels in the blood. So only in the blood they reduce the calcium level. How? Because they are obviously protecting the calcium in the bone. So there will be less calcium in the blood. So they are going to treat hypercalcemia. They are also used to treat metabolic bone diseases. So this is alendronate, which is a bisphosphonate. Okay. So overall, why do you use bisphosphonates? You use bisphosphonates to treat osteoporosis, to treat Paget's disease, to treat hypercalcemia, we already told you that, and to treat any osteolytic bone metastasis, because we don't want the bone to become broken, osteolysis. We don't want osteolysis. So we will give this to protect the bone. So basically in Paget's disease, what will happen? There will be abnormal osteoclast function. Do you know what osteoclasts are? These are going to break the osteocytes, right? So osteoclasts are destructive. So if there is any abnormal osteoclast function, there can be a Paget's disease, then you give bisphosphonates to protect the osteocytes, that is the bone cells. Okay. How's it going so far, guys? Are you understanding what we are studying today? We are looking at bisphosphonates, pharmacology. These are bone protecting drugs. They inhibit osteoporosis. They are going to protect the bone. They are going to reduce the calcium levels in the blood so that all the calcium can be in the bone. Everybody awake and listening, right? So now we are moving on. This is the classification of bisphosphonates, and we look at the potency of these drugs. So there's a first generation, second generation and a third generation drug. Hold on. So here, first generation, you see, this is the way they were found first generation, then they found something better in second generation, and third generation they found something much better, right? So basically that's how it progresses. Now the first generation drugs, actually they have simpler side chain and they have very low potency. You can see their potency is just this much. So they have simple side chain and low potency. They are not actually used now. Etidronate, Etidronate is a first generation bisphosphonate. Remember, everywhere as onate is common, right? Or ronate is common. Oh, ronate itself is common, or dronate is common. Wow, everywhere dronate is common. So etidronate, tiludronate, which is not marketed in India, pamidronate, alendronate, ibandronate, risedronate, zoledronate. Wow, all are dronates. Bisphosphonates are dronates. You know the drone that you fly? Yeah, all of them are bisphosphonates. Dronates they are. Etidronate, pamidronate, alendronate, ibandronate, risedronate and zoledronate. Remember, as the generations progress, the potency is increasing and increasing and increasing. The second and third generation, actually they have amino or nitrogenous ring, okay, substitution in the side chain. Hence they are more potent, okay. It's already written here if you are not able to see. Look at this, it's written here. The second and third generation have amino or nitrogenous ring substitution side chain, and they are more potent, more efficient, more efficacy they have and additional mechanisms of actions they have. Okay. So now let us look at the names again. So in second generation, you have Pamidronate. Pamidronate is given IV. Ibandronate is given IV. Zolidronate is given IV. Alendronate is oral. Risedronate is oral. See, this is a risedronate is oral. Alendronate you have seen in the previous photo. Correct? You remember you have seen Alendronate there. This is Alendronate. So Alendronate is given also orally. All these green ones are nice. They are oral. Right? Risedronate, Alendronate, risedronate are what? Oral. And Pamidronate. Look at Pamidronate here. Pamidronate is injection. This is second generation. Correct? So this is Pamidronate. Please go back and sit here. This is Pamidronate is given IV. Ibandronate is given IV. Zolidronate is given IV. This one is risedronate. Risedronate is like rice. You are going to take it orally. So classification of bisphosphonates over. Can you tell the classification? Yes. In the first generation, you have etidronate. Then the potency is very less, like 1 and all that. Then in second generation, you have Pamidronate, Alendronate and Ibandronate. Pamidronate and Ibandronate are given IV. Very good. Alendronate is given oral. Third generation, we have Risedronate, which is given oral, and Z, that is Zoldronate, which is given IV. Z is last, remember, third generation. Okay. So we are done with the classification of bisphosphonates. And we have seen their potency also. We have seen how the first generation differs from second generation, because the second generation have side chain will be amino or nitrogenous substitution ring will be there. Okay. Now let's come to the mechanism of action of bisphosphonates. So how do you think these bisphosphonates work? Can you give it a thought and think how they are going to protect the bone? Just give it a thought. So did you think how it might work? So finally it has to protect the bone. So the bone health will improve. Correct? Are you able to hear me? Okay, so there are two things that they are saying. First of all, it has affinity for calcium. This bisphosphonates, they have affinity for calcium. Where is the calcium? In the bone. So the, see, this is actually bone, and this is an osteoclast that's eating the bone. So osteoclasts destroy the bone. So what it will do, bisphosphonates, they will go and sit near the bone, right? And these osteoclasts take up these bisphosphonates. The osteoclasts are eating this bisphosphonates. Think about it. Then what happens? These osteoclasts are going to be destroyed. So you have bisphosphonates. Bisphosphonates have affinity for the calcium. Say they go near the bone. The osteoclasts pick them up, and these osteoclasts gets destroyed. The apoptosis of osteoclasts happens. So nobody is going to eat the bone. Easy, right? So basically, that is how it works. So the cytoskeleton of the osteoclasts get disrupted because of these bisphosphonates. Okay. The cytoskeleton of the osteoclasts get disrupted. So that is one way of preventing bone resorption. So it will prevent bone resorption. Okay. Then the second and third generation drugs, you know, they already have some additional metabolic effect. We have already told you that. What is that additional metabolic effect? It is mevalonate pathway of cholesterol synthesis. You have to remember this word, mevalonate pathway of cholesterol synthesis. It is going to interfere in this, mevalonate pathway of cholesterol synthesis. This pathway is very important for normal function of osteoclasts. Okay. The osteoclasts need this pathway. Osteoclasts need this pathway. So now what happens? The osteoclasts get inactivated. Okay. They enhance apoptosis again of osteoclasts, and they also have the second and third generation, they have anti-tumor activity. So some tumors want to destroy the bone, right? So these second and third generation drugs, example, Pamidronate, Zolidronate, Risedronate, Alendronate, these basically are going to have some anti-tumor activity. Okay, so you remember the classification, right? We have looked at the second and third generation drugs, that is Alendronate, which is given oral, Pamidronate given IV, Zolidronate given IV, and Risedronate given oral. So remember, 2 examples for oral, 2 examples for IV. Alendronate, Risedronate are oral, both are we have shown here in green. Alendronate and Risdronate. Then you have Pamidronate and Zolidronate. Pamidronate and Zolidronate are given IV. Etidronate is the first generation, not used much now, okay, because it has very low potency. So we are done with the mechanism of action. Now we will move on to the pharmacokinetics. Pharmacokinetics, you already know what is given IV, you already know what is given oral, right? So you can write the examples now, oral and IV. Come on, write the examples for oral. Alendronate, Risdronate. IV you will give Pamidronate and Zolidronate. Very good. Now, orally what happens, they are, the bioavailability is very low. So you should know that bisphosphonates, they are, guys, the thing with this bisphosphonates is that they are not available orally much. The bioavailability is very low. Okay, so they are polar, they are highly polar, and hence they are poorly absorbed by the GIT. However, still Alendronate and Risdronate are given orally. Just know that these drugs, right, they should be taken on empty stomach with lot of water. Then you should not eat for half an hour after taking it. There are quite some rules with this bisphosphonates, okay. So we'll just write that here. Take on empty stomach with lot of water, and don't eat anything for half an hour. Something like this. There are some crazy rules because the bioavailability of bisphosphonates is very low orally, okay. The thing with these drugs is that once they enter our body, right, they stay for months to years in the bones. So that is why most of these drugs, if you notice, just go back here. And if you noticed, if you see on these drugs, there's written something like once weekly. Look at this one. Risdronate. They have written on this. Once month, 1 month pack, only one tablet. 1 month pack, one tablet. So basically they will give only once a week or once a month. And look at this. Pamidronate. They didn't write anything on this. But injection anyways, Pamidronate and Zolidronate. They have, the thing is you can take it only once a year, it seems. See, this one is only once a year, Zolidronic acid, Zolidronate, okay. So, Zolidronate is given once a year, okay. So, you can give once weekly or once monthly, right. That's enough. And IV they are giving only once a year, okay. It is excreted unchanged in urine. Whatever goes to bone goes and stays there for months to years, and whatever is not taken up, it is just excreted unchanged in urine. Okay. So that was about the pharmacokinetics. Now we have to go to the uses of bisphosphonate, detailed uses we have to look at. Okay. We'll go to the details of each of these. Okay. Guys, shall we move on to the details of the uses of bisphosphonates? First, let's look at osteoporosis. Osteoporosis, actually the first choice of drug for osteoporosis is bisphosphonate. So remember that it is the first choice of drugs for osteoporosis. So basically, this is any type of osteoporosis like postmenopausal osteoporosis, age-related osteoporosis, idiopathic osteoporosis, steroid-induced osteoporosis. In any such cases, you can give bisphosphonates like alendronate or anything, okay. So these basically reduce the fractures which are caused due to osteoporosis. So it is the first choice. Remember, these drugs which are other than bisphosphonates, you can use estrogen, calcitonin, etc. But the first choice is actually bisphosphonate. Remember that it just protects the bone, okay. It does not help in bone formation, okay. So only it stops the osteoclast activity. It does not help and produce osteoblast activity. So because you understood, right? Only clasts which are going to destroy the bone, that is going to be stopped. So bone destruction is going to be stopped, but bone formation it will not help. Okay. So we are done with osteoporosis. Next we are going to Paget's disease. Paget's disease, what you already saw is abnormal osteoclast activity. But this Paget's disease of nipple is also there, right? What is that? How do you separate those two here? So this is called as Paget's disease of bone, remember, okay? It is of bone, not of the nipple. So Paget's disease of bone, what happens here? There's abnormal osteoclast activity. So there is going to be bone destruction. So now you want to treat this disease, that is Paget's disease of bone. How? You will give bisphosphonates, right? You will give the second and third generation bisphosphonates. This will reduce the bone pain. Then you can combine these bisphosphonates with calcitonin to increase the efficacy. Okay, you can combine with calcitonin to increase the efficacy. Don't give this treatment more than 6 months. Okay, that's enough. Very short course treatment is enough because the T-half of these drugs is actually very high. Okay, so we are done with Paget's disease of bone. Now let us move on to hypercalcemia of malignancy. Just before that, one point here is this osteoporosis. If you're giving alendronate, don't give it more than 5 years. Why, you know? Because alendronate has a T-half of 10 years. So you don't give it more than 5 years. That's why all these drugs are like once weekly, once monthly, just once in a year, such kind of drugs these are, okay? So in Paget's disease of bone, don't give more than 6 months treatment. Now we are moving on to hypercalcemia of malignancy. People, we are looking at the details of the uses of bisphosphonates, BPNs. Okay, they are called as BPNs also. So these BPNs, we have looked at the first two, osteoporosis and Paget's disease. Now we are moving on to hypercalcemia due to malignancy. Okay. Now hypercalcemia due to malignancy. So due to some tumors, the calcium levels can increase. So this could be a medical emergency. If it is with dehydration and altered consciousness, then it is a medical emergency. In this case, you can give first IV saline. Okay, saline itself will reduce serum calcium. So saline is the first step. Remember, saline is the IV saline is the first step, and then after that you can give them these IV BPNs like Pamidronate and Zolidronate. Okay. So these are very effective, but they will take action in 24 hours. You can give calcitonin intramuscularly. After this volume repletion, furosemide is added, okay, to increase the excretion of calcium. Oral bisphosphonates are not actually very useful. So that was about hypercalcemia due to malignancy. Remember, if it is an emergency, if it is with dehydration and with altered consciousness, you have to give IV saline, and then you have to give these IV BPNs, that is bisphosphonates. Benign prostate hypertrophy is BPH. So don't get confused, okay? BPN is bisphosphonates and BPH is benign prostate hypertrophy. That's in pathology. Okay. Coming to last one here, osteolytic bone metastasis. Guys, osteolytic bone metastasis means definitely some malignancy, right? So here, basically this metastasis is going to the bone and destroying the bone. So this type of tumors which cause osteolysis, that also you can protect by giving Zolidronate example. Zolidronate is the best. So it will reduce bone pain, it will reduce even the carcinoma recurrence, which is really good. So any tumor that causes osteolysis, right, there you can give Zolidronate to stop this osteolysis. Okay, so that was about bone BPN uses. So we are done, guys. We have looked at the details of the uses of BPNs. Okay, so hope you have liked this much. Now let us move on to the adverse effects of these drugs, guys. At the end you should know the adverse effects, the contraindications and all. Okay, so are you ready to look at the side effects of bisphosphonates? So the adverse effects are like, if you are giving orally, then there will be nausea, vomiting, all that standard things you'll write. Main thing is esophagitis, very, very important. You should not forget. That's why you should not allow bisphosphonates now when they give the tablet or anything. You should not chew it. You should not break the tablet and take it. Because if the tablet comes in contact with the esophagus, it can cause esophagitis, erosion, ulcers, etc. So you should not break the tablet. That you should write here. Don't break tablet, so that it directly avoids contact with esophagus, okay? Don't give if the person has peptic ulcers, etc. If you are giving IV, then there can be thrombophlebitis, correct? That is all local pain, etc. That's all standard things you will write. Thrombophlebitis means actually inflammation that causes a blood clot to form and blocks the veins, okay? So inflammation leading to blood clot, leading to block vein. That is thrombophlebitis, okay? So all these, and then flu-like reaction can happen, fever can be there, leukopenia, so it's going down, okay? Leukopenia can happen. Zoledronate has a very specific adverse effects, that is osteonecrosis of the jaw, okay? Remember, Zoledronate, osteonecrosis of jaw, don't forget, okay? So these are the adverse effects of bisphosphonates. We are done. Let's take a quick recap of what we have seen in this video. So we started off with the pharmacology of bisphosphonates. It says bisphosphonates are for bone health. It will protect the bone. Introduction, we saw they help in preventing osteoporosis. They treat hypercalcemia. They inhibit bone resorption. They treat metabolic bone diseases. So basically they have 2 phosphates with some side chains. We have seen the structure, 2 phosphates with some side chain. We saw their uses. Very overall, we saw it is used to treat osteoporosis, Paget's disease of bone, hypercalcemia, osteolytic bone metastasis. Okay. We saw the classification. We saw the first gen, second gen and third generation bisphosphonates. Examples are Etidronate, then you have Pamidronate, Alendronate, Risedronate and Zoledronate. Pamidronate and Zoledronate are given IV. Alendronate and Risedronate are given oral. First generation are not used. Then bisphosphonates, the mechanism of action, they are going to inhibit the osteoclastic activity. Also, they are going to interfere with the mevalonate pathway of cholesterol synthesis. Mevalonate pathway is important for the osteoclast. So, the osteoclast gets inactivated. Hence, there will be apoptosis of these osteoclasts. So, less osteoclast, bone is kept safe, right? So, bone health is preserved. Remember, it does not, bisphosphonates don't help in making the bone. It only helps in protecting the existing bone, okay? This is very important. You can write this point. Then, we saw the pharmacokinetics. Pharmacokinetics is like, so basically these bisphosphonates, orally the bioavailability is very less, okay. So if you think about why, it is actually they are very highly polar, so they are poorly absorbed from GIT. So these are the advices they tell, with bisphosphonates. Pay attention here guys, wake up if you are sleeping. Very specially for bisphosphonates, they say this, take them full, don't break the tablet because it should not touch the esophagus. Otherwise it will cause esophagitis, ulcers, etc. So it should be taken on empty stomach with lot of water so that it is absorbed. Don't sleep or eat anything or drink for half an hour after taking tablet. You should not do anything. Don't break the tablet, etc. So these are very specific things that are there for these bisphosphonates, okay? And these drugs are given like once weekly, once monthly, once yearly because their half-life is so huge. And you should not give them in long therapies. You should not give them for 5 years, etc. You should give them like for, what did you see? For that Paget's disease of bone, you should give only for 6 months. And this Alendronate has a T-half of 10 years, so you should give only for maximum 5 years. In IV, Pamidronate, Zoledronate is given actually only once a year. This is Zoledronate, look at it. So it should be given only once a year. The drug actually reaches the bone because it has affinity to calcium phosphate. Remaining will be excreted unchanged in urine. The details of uses of bisphosphonates we saw. Postmenopausal osteoporosis, steroid-induced osteoporosis is the first drug of choice for osteoporosis. Paget's disease of bone you can give to reduce bone pain. You can combine it with calcitonin. Hypercalcemia due to malignancy, if there's hypercalcemia, if there is an emergency because of dehydration and altered consciousness, you can first give saline infusion. That is very, very important because saline itself lowers the serum calcium level. Then you can give Pamidronate and Zoledronate, which are effective. You can also give calcitonin, IM. Then you can give furosemide, okay. So, calcitonin, furosemide also you can give. Pamidronate, Zoledronate are the BPNs that you give. Okay. Saline infusion is the first step. Remember, saline itself lowers calcium. Oral bisphosphonates are not very useful in hypercalcemia. Okay. Coming to osteolytic bone metastasis. In this case, osteolytic bone metastasis, because of malignancy, if there's osteolysis, then you can give Zolidronate. It's the best. And it will reduce the bone pain and etc. It will also reduce the carcinoma recurrence also. So it is really good, right? So that was about the uses of bisphosphonates. Okay. In detail, we looked at the uses of bisphosphonates. Now, last slide here we have on the adverse drug reactions of bisphosphonates. Because it is given GI, nausea, vomiting, you can write headache, dizziness, all that standard things you can write. Esophagitis, erosion of esophagus, ulcers, very important, so don't break the tablet. Don't give orally if the person has peptic ulcer, it is contraindicated. This will be a contraindication. Then if you're giving IV, there can be thrombophlebitis, local pain, etc. Flu-like reaction can happen. There can be leukopenia, and Zolidronate causes osteonecrosis of jaw. So this is the photo that you should not forget. Zolidronate can cause osteonecrosis of the jaw. So that covers bisphosphonates. Hope you have enjoyed this lecture and hope you will keep your patient's bone health. And that's all for now. Tata, bye-bye.